Going to be very useful. This is our next session starting up now, and I've asked the professor to stay with us as he will be joining the panel there. And this one is the first of the main sessions, if you like. The other one was the inaugural session. This is Strengthening Health Systems, Lessons Learnt. And I'm going to ask the other panelists to come up, if I may, please. I think we have Dr. Phillida Travis is here with us. Please come up, ma'am. She's the Director of the Health Systems Department of the World Health Organization Southeast Asia Regional Office. Thank you very much for coming up. Thank you. We also have with us Dr. Jagruti Bhatia. Please come on up. The Senior Advisor for Healthcare Practice at KPMG. Coming up. Thank you very much. Pleasure to see you. We also have Dr. Ashish Kumar Tiwari. I don't know if his flight has got in yet because he sent me a message saying earlier that his flight was delayed, but we'll bring him on and get his involvement too. He's the Chairman and Managing Director of ACS Health and CEO of Zenova Hospitals. And he's coming up from Mumbai. He'll be joining us hopefully very shortly. So one thing I sort of always point out is when it comes to lessons learned and your health, never upset someone who can do you some real harm. And I illustrate that with a story I heard about a lady who went into a pharmacy and she walked up to the pharmacist and said, "I'd like to buy some cyanide." And the pharmacist said, "Madam, what on earth would you want to buy cyanide for? I can't just sell you cyanide. What do you want to do with it?" She said, "I want to poison my husband." He said, "Madam, I can't sell you cyanide to poison your husband. Are you crazy? I'll go to jail. I can't do this. We'll both go to jail. This is going to be disastrous. What on earth?" She calmly reached into her purse and pulled out a photograph and showed him a picture of the pharmacist's wife in bed with her husband. He said, "Madam, oh, that's different. Of course, I didn't realize you had a prescription." So don't upset those who can hurt you. You don't need a prescription, of course, to take part in our discussion today, which is great. So what I'll do here is pick up on the conversation, the way we were discussing the issues of the overall context of why we're here and what we're trying to achieve here. And obviously, a number of key issues did come up in the first part of the discussion, and they will evolve throughout the day. What I'm going to do here is just to ask, if I may, each, again, of the panelists, we heard from Professor Brandt, so I'm going to ask Ms. Bhatia here, really to ask, on this issue of healthcare and building systems, what do you feel is the one area of priority that we really should be looking at in India? And if you look at what's outside in other parts of the world, in Europe, we're using as an example, what do you think is the one area of priority that should be a focus now?
Thank you, Riz. In terms of the priority areas for building a good health system, I think, we have, I'm sure a lot of our other panelists have, reiterated that there is a lot of big problem to handle. So we have a double burden of disease. We have both the communicable diseases as well as the NCDs taking a toll. I think on tackling the disease front, there is a lot to be done in terms of infrastructure, resources, how we go about ensuring quality, and how to make this whole care affordable. PPP, one of the examples that we've given. I think building a trust between the private and the public sector. At a policy level, and Ranjana mentioned very clearly, we had a lot of hope, and though I'm still hopeful, but at a health system level, I think, to make the care more accessible, affordable, and, to reach out to the rural as well as the urban areas. There's a lot to be done, actually.
And I was going to ask Dr. Bhatia, what are the sort of indicators here when you look at these issues? You mentioned communicable and non-communicable diseases. These eat up a lot of resources. How can there be a balance struck when trying to deal with these kind of issues on the scale that India has to deal with them, and then also trying to, at the same time, build the infrastructure for a kind of sustainable healthcare system?
So, we have, as we know, the whole public sector, the way it is arranged is in a three-tier system. We've done some assessments at, both the rural as well as the urban areas. Sadly, when the government has a lot of infrastructure which is available at the reach where the population is, there is the building there, but there is the lack of manpower. There is lack of the doctors actually being there.
We're talking about the 4 pillars in effect here, aren't we?
Yes.
Yeah, if you take us through those, so we've got the...
So, in terms of, increasing access, that's on the primary care side. So we have a lot of public primary healthcare centers and the CHCs in the rural area, which is the government infrastructure. Now, when we want to increase access, one of the areas that we look at is, say, improvement of technology. Can telemedicine be used? can we have e-consults done? And it is not that it is not achievable. You take the example of Arvind Eye Care, which is actually, it's even a Harvard case study. For example, they have really managed to take the care out there to the rural area. So can telemedicine be used? Can mobile health be used? The government of Maharashtra, for example, has done a very, recently started an exercise on M-Health. And that's where you actually help to reduce the maternal mortality rate and the infant mortality rate, where you are going to the rural areas and the health workers are actually given mobile applications through which the mother and child health is being tracked back, and it is monitored at the state health departments. So this is something that can be done.
So that's where you have the access. You have also then affordability is one of the other pillars.
Yes. So on the affordability front, health insurance, I think plays a very big role. Unfortunately, only 37% of our population is covered, today with any form of health insurance, which includes CGHS, ESIC scheme, as well as the corporate schemes and all. There's a lot to be done on that front. We hope that either we have something like a health fund that can be put up. Now, this is all level that will require policy changes, and to make the healthcare more affordable. Also, looking at costs, looking at making free drugs, essential drugs available to the larger population. At the same time, can medical tourism be used, as a cross subsidy? Can there be the whole subsidy and the trust between the private and the public sector actually done?
And actually, so that's interesting because really we've touched on accessibility, affordability, and what was the other one? There's acceptability is the fourth.
Yes, so the acceptability is something which is a very subtle, parameter. Though this is something from practical experience what we've seen. Largely a lot of PPPs in healthcare have essentially, many of them have failed to take up, essentially because I think there is a lack of trust between the private sector and the public sector. And that's where both need to, first of all, there should be acceptability for both of them to, trust each other to build this whole health system out. The second one is obviously also on quality. Quality as today becomes, it's a very, it's a voluntary option today. But can that be really, can that be regularized? So that can there be a legislation which mandates quality standardization?
And enforced.
Yes, so and enforced. So that's.
Dr. Bhatia, thank you. You've raised some interesting points which we'll expand on through this conversation. I want to bring in Dr. Phillida Travis now as well. And it's interesting because we, at this conference, we're talking about, in this session especially, strengthening health systems, lessons learned. And it's under this umbrella of universal healthcare. But I know that term is touted heavily, and I want to get your definition of how we should really look at the concept of universal healthcare. Are we using it without really understanding what it should be?
I think we all have different understandings. I'll give you the term that's been, the way WHO uses it, and it boils down essentially to two dimensions. The first, and they've both been touched on already in the conversation in this meeting. The first plank, if you like, is ensuring all people have access to the services they need and they're of adequate quality. And the second plank is that they're not impoverished as a result of seeing healthcare. So those are the two dimensions, and so it builds on the thing that covers acceptability, availability, and you cannot move on these two dimensions one at a time. There's no point increasing financial access if you haven't got services to be delivered, and that's the experience, frankly, with all health systems. You can't do it sequentially.
So then, in terms of when you look at the situation in India, how do you see the next steps in designing and building something?
I've been in India 10 weeks.
Oh, well, that's true.
But I can talk to you a little bit about some of the experience in other countries.
Please, yeah.
In the region.
No, you've got a big job ahead of you, so that was a bit unfair, but yeah, please.
No, but I think there are some principles, and I think Helmut Brand and others have already touched on them. I mean, for example, in the region, 40 million people a year are impoverished as a result of health spending, and a big part of that comes from India, because India is the biggest country by a mile in the region. So there is work to be done on looking at how to increase prepayment, because out-of-pocket payment massively increases the risk of impoverishment. And out-of-pocket payments in the region range from 16 to 84% across, I'm being very bureaucratic here, the 11 countries in the, that count as Southeast Asia according to WHO. Huge range. Thailand and Bhutan have the lowest out-of-pocket. India's around 60 to 70%, depends what estimates you read. So there's a lot to be done on moving to reduce out-of-pocket spending. And the second aspect is improving access to services. And there I think I would agree with other speakers, there's no single best buy or single model. You have to start with the system you've already got. In India, it's a big mix of public and private. The key is to make sure that those services are of adequate quality and affordable, and particularly to not lose sight of the poor, who are often those that can speak out least for themselves.
And of course, WHO is an organization that, I mean, generally most parts of the world turn to if there is that kind of need of expertise and understanding. And you're bringing in the general Asian experience into India with you as you come here. Professor Brandt had mentioned earlier how Thailand had reformed its system. I wonder really, when you look at these lessons learned, you said you can bring in that expertise. What sort of things you've seen that you feel, what particular areas that you feel that you can actually then start to see as having potential for India?
Well, I think one big message is that it does take time, but you can always do something wherever you're starting from. So in Thailand, it's a story over 30 years, progressively. They also tackled services as well as financing at the same time. I think you can learn from the Thais' mistakes. They would themselves say they made a mistake initially by having lots of very small financing insurance schemes, which they then had to pool and merge, for example. So, but often I feel that Thailand is the only example people draw on from it in this region. I think there's good experience in other countries as well as Thailand.
Excellent. Maybe you can touch on some of those. Professor Brand, that's one of the key things that we look at when we look at Europe and we look at India in making the comparison. Of course, Europe has had this major issue with the financial crisis. And I know you've when you and I have talked off stage, if you like, you talk about how those who had good systems in place are the ones that survived. The good elements, kind of the good foundations, helped to keep, even through the financial crisis, kept things solid. Is that right?
Yes. When you are in crisis, it's always the same. If it's your company, in family business, or in health systems, there are things that you can do on short notice. The low-hanging fruits: increase user charges, cut salaries, reduce opening hours, all these things. But they will not solve the problem. And all those measures that can really bring about change need time and money. And those health systems that has done their homework before the crisis or had a constant reform process dealing with this had a better outcome. On the other hand, one has to say there are mostly the richer ones too. So there is a link to the money available in the system. But regardless of this, there seems to be several issues. You said we need the move from post to prepayment. Getting rid of co-charges, and we see the same in Europe, that there are still in some countries, especially outside the European Union, but even in there, a kind of history and a mentality for under-the-table payment and for co-payment. And in some countries, it's even the case that a family has to decide when the wife and the husband are ill at the same time, who gets the treatment. And often the husband gets it because he has a job. And that's a recent story from Albania, where they are now trying to tackle this. And as long as we have this kind of discussion situations, our discussion sometimes is a little bit tricky. So we have to find ways how to deal with this. In Europe, co-charges are often used to decrease demand. You know, if you have to pay an entrance fees for a doctor, the theory is, the economic theory is that it will reduce demand. If this really works, that's a totally different story, and I think we will come to this in the afternoon. It's a matter of trust. If you bring your car to a repair shop and they say, oh, you came because of the brakes, so we changed them, and we just changed the clutch too because it was faulty. You can argue, well, why did you do this? I know it was working, so you did something not necessary. Try this with your doctor. Yeah, if he says to you, come back again for another test, and you argue, well, I don't believe you. You just trust. There's an asymmetry of information.
Right.
And so we have to build systems where people have trust in, regardless who's running them. You can run this by a charity, by a private enterprise, by the state. It's most important is that we have a system where there's trust in the healthcare workers, that they not rip you off. I say it very blunt here, because if you spend your money there, it might be the only money you have. Right. So the government has a duty to organize a system that can has a kind of framework setting. And it's possible. And even in Europe, we did not expect to see a medicine agency when the Maastricht Treaty was, and suddenly it was there, and everyone said in the beginning, oh, that will never work. 28 countries or 15 countries at that time, they will never give up the sovereign right to discuss about what kind of medicines are on the market or not. And it happened. Yeah. So there are some possibilities, and I think that the new generation of Indians will have clever ideas how the situation might be solved. The new ideas about healthcare reforms come not from Europe, they come from Asia.
And it's interesting, this issue you said about being ripped off, the whole issue of transparency and how that can be handled is something I do want to tackle throughout the day as we get on there. I had an interesting story of a friend of mine from South Africa living in Atlanta in the US. His father came to visit him from Durban and had heart pains, chest pains, went in for some tests, he had a mild heart attack, and the hospital put forward a bill of $64,000. He spent 2 nights just having tests. So my friend called him and said, what on earth is this bill for $64,000? And the woman said, oh, I can hear you're not American. He said, no, I'm South African. And she said, well, how it works here is you'll have an insurance adjuster who will argue with the hospital, and they'll probably end up paying about only half. He said, well, healthcare in my country is not negotiable. And he said, what's the breakdown? How do you get a bill this high for just 2 nights of tests? The stay per night in the room was $10,000. I don't know many hotels that even charge that much, but and his bathrobe was $1,000. Cotton swabs were $5 each. It was this kind of bizarre menu of charges. So it's something we will look at when we looked at the affordability issue as well and the transparency. I do want to get the questions in while we have a few minutes. And sir, you had your question up. If we can get you a microphone, just put your hand up nice and clearly. If you put your hand up, we can get you the microphone, yeah. We have the microphone there, please. Ladies with the microphones. Anyone? Could bring it to the front, please. Thank you. Tell us your name and your affiliation, please, sir. Just talk into it. Try it first.
My name is Anil Khaitan. I'm from Sunil Healthcare Limited. I had certain observations and certain points to make.
Please.
Most countries always talk about healthcare. But then they forget as to healthcare needs money. And when we see they are unwilling, or the government is unwilling to commit those funds towards healthcare. Now taking the case of India. Now India, maybe 0.9 or 1% of our GDP is being spent on healthcare. That is why Ranjana would also bear me out that the private sector is contributing 80% towards India's healthcare. And government has to increase their spending, which we've been asking the government. And let's hope they listen to us, especially now with the new government in place, that at least make it 3% from 0.9%. Okay. Coming to the second point is the capacity utilization of the pharmaceutical industry in India today is as low as 45%. So you can imagine 55% of idle capacity is lying in India, which can be very, very well utilized with proper strategic intent and decisions to see that quality medicines, generics, are supplied to one and all, right from east to west and north to south, which is the idea that accessibility of quality medicines to all, which is not happening, because only 40 to 45% of India's population are accessible to quality medicine. So that's one major issue which the government is now addressing through these Jan Aushadhi stores, because the Prime Minister wants that government will do the tendering and they will do the procurement.
Okay.
And then to have an independent company like they have in Tamil Nadu
Right.
for the supply chain management.
And just the 2 points, Anilji, or you have one more point?
Yeah. And the last was that we in India, we basically have 4 or 5 fathers in terms of pharmaceutical. You know, we have to go to this ministry and that ministry and that ministry. So now I think the government is now thinking that they will create a new ministry, which will be the pharmaceutical ministry, and with the independent Minister of State, and under which the medical devices sector will come. So now to conclude, my only basic plea was with the European Union that if they could assist India in showing us the path to accessibility of medicines to one and all. Thank you.
Okay. Thank you very much, sir. Let me start with that first part, the increase in spending. I don't know, Dr. Bhatia, if you're able to tackle that, the kind of potential for increase, getting government to put more money into the health sector.
So, one of the, so that is something that we just can hope for, that the percentage allocation to the GDP increases for health. But the government is looking at, say for example, alternative methods. One of the alternatives was the PPP model, and we've seen that being rolled out, in various states. This is also being done across various sub-segments. So earlier what we had seen was just on the diagnostic side, but today they are also looking to roll out PPPs in the cardiac centers, in key clinical areas as well. That will actually help to improve the standards of quality of care, but we have to put in the right checks and balances in place so that the affordability needs to remain at a level where it is where it should be. So this is something that we are looking at.
Let me ask perhaps Professor Brandt if this idea of the pharma capacity could be cranked up if it's really less than half.
Yes, for internal use and export, you can of course deal with this, and we have to see how the development of the new pharmaceuticals in the pipeline, when the IP right ends, what will happen then? How is this model of generics as we know them sustainable for the next 20 years? Because we are talking about this kind of investments. So let's see how this will do. There will be a set of pharmaceuticals where you can use generics all the time, but for a lot of things, I think the market might change. Regarding the PPP, we just produced an opinion on public-private partnership of the expert panel on investing in health for the European Union. Our biggest problem was to find evidence, published literature, published evidence about the results of PPPs. Because, of course, companies don't want to have you look in their books, how profitable, so that the others can choose. But we need this to make a decision, does it really work? And at the moment, it's unclear if PPPs really are of benefit in the end. In the UK, a private company gave back running the license to run a hospital because the system was not ready and they could not deal with this. So I think India has one hidden chance, that is to provide a lot of new knowledge and evidence so that we can make better decisions about healthcare reforms and what health systems really work. And this PPP issue, as you will do this, please, please, please put some measures in that you can produce knowledge for us too.
Well, Dr. Travis, of course, I see you nodding there, so I'll get your take on this too. And also ask you to comment on this, the third aspect that Anilji was mentioning there, the idea that, look, with multiple ministries, it's much harder to navigate the system. I know WHO, of course, you have to deal with so many elements of a country's sort of government as well. I wonder if the idea of a single ministry, for example, might make life easier. I don't know.
The mother of all ministries.
The mother of all ministries.
I'll come back to that one. Just a couple of points on what's been said. Evidence. I have been really struck coming from Europe, where I've been working for 20 years, to Asia. There is so much experimentation going on in Asia, and it's not being that well documented. And I would really reinforce the plea for good quality documentation and monitoring and evaluation of experience, and also to not just do little assessments of one project and did it work in one district, but look at what might be the lessons and the impact on a wider system-wide scale, because that often doesn't happen. You prove something works very nicely in India, nothing's on a small scale, but you prove something works nicely in one state. What are the lessons for a much larger scale? So the evidence stuff is really important.
We'll touch on big data, by the way, a little later too, so that's going to be
yes, and I'm interested. I'm very interested. If I can be here for that, I'll stay. The other thing I just wanted to comment on is that I'm really conscious in this meeting, it's quite unusual for me, so many people, it's a meeting about UHC, but a lot of people are here from the pharmaceutical industry, and that's both encouraging, but it's also a risk that when we talk about the UHC agenda, we focus on the medicines aspect. It's nice that it's being discussed, because often it gets neglected. But I think the other huge plank of UHC, apart from the financing side, is the health workforce issues. And certainly in WHO in Asia, we're trying to move on both these fronts, the medicines and the HR issues. On the business of multiple ministries, you have to somehow navigate. It's easier. I think China must be the hardest one that I've come across. I think what you do is you have to pick specific topics, and I have a colleague in the office I work in here who's doing a survey of 10% of all the small and medium-sized pharmaceutical enterprises in India with the government, and it is involving working with multiple different, not only just ministries, but also different regulatory authorities to get that survey done. And if that hadn't been managed at the start, nobody would be interested in the results. And I think that's the way to work. You work around specific issues, not try and get everybody together on every issue.
Right.
Thank you.
Thank you very much. Thank you, Dr. Travis. Actually, on the issue of medicines is good. We also have Dr. Anita Wagner here as well from Harvard Medical School. I know you'll be talking about that a bit later too, so we look forward to comments on that. I want to actually, do keep your hands ready. We have to take a quick refreshment break here, and we're going to carry on with the next sessions. Please, a round of applause for our panelists. Keep in mind, though they're not going to be on stage, now they will be amongst us to be able to talk and discuss issues, and I will be drawing on you also for comments and questions as we come up, so I appreciate your contribution. Thank you very much. Just for the sake of timekeeping, if I could ask you just to take a 15-minute, a little sort of networking and a refreshment break, and then come back in. We'll start the next session and before lunch, if we may, please. Thank you. Do hold the questions. We'll get to them. It's all going to flow in together. Thank you. Dr. Butler, thank you so much. Thank you, it's a pleasure. The break is 11:15. Oh, it is 11:15, isn't it? Oh, where are we at now? No, it's 10:35. Should I carry on? Oh, actually, Dr. Bhatia, actually join us again. You know, we've been postponed this a little bit, so let's carry on the conversation just a few minutes. So we'll take a few more questions. That's me going a little crazy with my watch there. I'm going to ask you to come back. Come on up. Is it okay, Professor and Dr. Travis, we carry on a few more questions, if we may, before taking the break, so just make up a bit of time. We had a few hands go up, so I'm going to try and get them. Sir, you were next, then I'll come to you, and then the young lady there also had a question. So if we can get the microphone first, I will come to you as well, thank you. Sir, put your hand up and we'll get you the microphone. Just there, thank you. Sorry about that, we'll just carry on a bit more, we've more time to talk. So, I'll get to you as well, don't worry. I see your hand as well, don't worry, I'll get to you.
My name is Sanjeev Vyas, and I'm from...
A little closer, sir.
My name is Sanjeev Vyas, and I am from USAID. And thank you for the excellent panel. And what I wanted to highlight is that the government will do things in a way that they best know how to do. So while a lot of advocacy efforts are required with the government, unfortunately for us, we have a very dynamic private sector in India. And wherever there have been gaps, the private sector has risen to those needs. For example, the bottles of mineral water lying on your tables. or the opportunity to create power through electrical gensets, which is a big market that the private sector has created in India. Now coming to primary care, while government is looking at expanding its network, but there's a great opportunity for the private sector here as well. And that takes me to a very nice quote from marketing which says, there is a niche in the market, but is there a market in that niche? So we need to understand that. And while there are a lot of post-incubation models that are available in India, for example, someone mentioned the Arvind Eye Care, the other models like the HealthSpring model, the Swasth India model, but where some of these entrepreneurs are struggling is really to how to scale up. So what we really require is a strong equity fund, which can really help these people to scale up. That's one of the challenge these people are currently facing. And can the panel tell us how such issues have been tackled in Europe and in other places?
Okay, perhaps Professor Brand, you could start with that, looking at how Europe has dealt with it. Then perhaps Dr. Bhatia, I can get your perspective on how it might work here, if that's okay.
Well, that's very difficult, let's say.
Because different parts of Europe, yeah.
Yeah, we have to see how to figure this out, because the perspectives and how this market will develop are different. And it's hard to make predictions, especially when they're about the future. But in this area, I would see more that there would be some frameworks from the European Union, and then let's say those who are the stakeholders will find their way around this. So that is something where I think every continent has to find its own solution.
Right. Dr. Bhatia, your perspective on what might happen here then? Is it a system that could be introduced?
So, in the Indian context, I think whatever we are doing is already there, and I would agree with him that we do have a very robust private sector, which actually really comes up and fills up the gaps while the government is at a policy level trying to make all these changes. And primary health care is something, so one of the areas is that the PHCs today are even, so they don't have a general physician, okay? This simply because that's the format doesn't allow that. And then it is only after the population reaches more than 50,000 is when a physician is there. So like, should rightly mention the issue of putting the manpower there in place. If you do not have the manpower there in place, can technology make a replacement for that manpower? And can government and the private sector come together and enable that happen? That's where I think we will increase the reach in the primary care.
Dr. Travis.
I might just add one thing, and I speak as someone who worked in the European healthcare system, and now I'm working in Asia. I think this business of the private sector, it's very varied, number one. The second is what matters almost more than the ownership of an institution, is it public or private, is how you pay and who pays. And the key thing that you have to think about when going to scale is, are you actually extending access for people who are not getting access, and not just extending access for those that already can afford it. Mm-hmm. So one has to watch the costs, but the way you pay, whether it's public or private provider, is actually often what determines both access and cost.
And when it comes to like tiered strategy, is it possible to create tiered strategies that would be a little more sensitive to that?
Well, I'm not sure if I understand what you mean by a tiered strategy. You can have different types of strategies for different types of
Well, I was thinking in terms of
groups.
trying to take into account affordability, whether there could be something that takes into account the disparity you have in a country like India at the bottom level and at the top level. You have that kind of middle ground where you have the developing middle class that can start to take on the private sector more, for example, and
you can have strategies, but they have to be designed with all the different groups in mind right at the start. And one of the lessons, I think, and Helma Brand can either agree or disagree on this, is that when you've tried to extend access, for example, through insurance, if you go for voluntary insurance, that really does not work as a strategy for long-term increasing access to everybody. Some form, I mean, I agree with people who said it doesn't matter whether it's tax-based or or social health insurance, this sort of merging of Beveridge and Bismarck. What matters is that you don't start buying off small sections of the populations. And that's the experience of, I think Thailand did it. Often people start paying the civil servants, giving civil servants insurance. That's not a good approach for the long-term pathway to UHC.
Okay. There was a hand that went up at the back. I'll come to you in just a second, ma'am, but there was a hand that went up at the back first. That was the gentleman in the middle. Then all right, maybe we've got the microphone to you first. And then, sir, I'll come to you in a second. Let the lady first. Please go ahead. And then we'll get the microphone over there, and then over to you.
Angela Brandt, Maastricht University, Netherlands. I still think when we look at health systems, we look at health systems as a silo. And now we heard this morning a lot of complaints, cutting costs, and that's in the healthcare system, that's very understandable. On the other hand, one has to see that health never almost was explicitly on an agenda, on a policy agenda. So on the other hand, a lot of other fields contribute to it. Economics, infrastructure, innovation, environment, etc. And so in Europe, for example, there had been years ago under the Finnish presidency developed a model of or approach of the health in all policies, and which we still not use so much, I would say, and could reinvent that again. And something like a global health in all policies, or an India health in all policies, and to really think what are the is a core business of the health systems, and what are other systems, the economic system, innovation, ministries, for example, which have really more and more also tasks linked purely to health. And so we need, I think, more creativity, and there's a lot of money. And I think to get more out of these health system silo is very important. And we have that with ministries of Minister of Environment and Health, or Minister of Innovation and Health. And there are many or some fields where I would, in the moment, put power more into Ministry for Innovation and Economics as in health.
It's an interesting idea, so to focus on the innovation to see it. Actually, Dr. Bharti, that's an issue here with India. I wonder, do you see any kind of generational change with the younger generation? Their expectations being different. They're aware of technology and what it can do. They've seen how telecoms has changed the country and created accessibility in some ways, communication-wise. Do you see a generational change in this idea that innovation can be more easily implemented because there's now a layer in the society which says we know what we can expect and we demand it and we want to move towards it?
Yes, sure there is, and that's a very, very good observation, Riz. So the whole new generation, whether it's urban or rural, the mobile phone, it's probably the largest amount of reach that is there for India. And it can really be used as a tool to tackle some of the health issues. Some of the primary care consults, can they be put on mobiles? And there are a lot of examples on innovation in healthcare happening across the country. I mean, time is too short and, to give examples, but, there is a lot that can be done. So the generation has moved up. So the new generation is more aware of a lot of things that can happen. They're also open to travel across, so because they do go to urban areas for work and other things. The awareness is much higher. Literacy rate is better. So things in terms of the new generation, yes, there is a lot of awareness.
Let me do one thing at this stage. Let me invite up Dr. Ashish Kumar Tiwari. Thank you, sir. I'm sorry your flight was delayed. We can certainly get you in here. We've got a conversation. Please join us. So, Dr. Tiwari is the Chairman and Managing Director of ACS Health and CEO of Zainova Hospitals as well. We've been discussing on this idea of how to strengthen the healthcare system here. The discussion has looked a lot at how public-private partnerships might help, how the government has certain responsibilities, and of course the private sector, the public sector has certain responsibilities. Your experience has been in both. And I wonder if you just look at, do a quick comparison here of where India stands on how you've seen what's happened in the public sector and what you see now in the private sector. Give me an idea on how you see things moving forward to strengthen the healthcare system in this country, sir. There's a microphone there. Just speaking to it.
Good morning to all of you.
Hold
there
it
are
quite
few-
close.
Hmm.
Yeah.
Can you hear me?
Yeah.
Okay. There are few key parameters for the healthcare universal health coverage. As far as India is concerned, we need good infrastructure, good professional manpower, which includes doctors, nurses, technicians, pharmacists, dental doctors, equipment, and other support system. You see, the cost of healthcare in this country, as far as private sector is concerned, is costly. That is not accessible to the common man. And in government sector, hospitals and healthcare infrastructures are too low to cater the population. So there is a disbalance between what is the need of the hour and what we are going to give them. Currently, as far as manpower is concerned, we are having 30,000 doctors in a year, but requirement is much more than that. So in future, we need more medical colleges to produce more doctors, more nurses, more technicians. And Government of India recently launches a movement that is Make in India. You know, around 35 to 40% of the cost to build a new hospital goes to equipment. If we promote this Made in India concept, definitely we can reduce the cost of equipment and we can produce more health infrastructure in this country. Currently, this government has decreased the health budget with reference to GDP. That is a bad news, sad news for the country. We were expecting that there will be more budget for the healthcare sector, but 20% reduction is there now. So for this year, there's not a good hope. This government is also promoting alternative medicines like Ayush. Ayush means Ayurveda, homeopath, and other faculties of the medicine, not allopathy. But this country needs more and more healthcare system in allopathy. So we should consider and we should force the government to look into this matter. Health budget must be increased. Without health budget and without the commitment of the government, healthcare is not going to be on the top. This should be the first priority of the government. And in current government, it is, I think, lacking.
Let me ask you, Dr. Tiwari, is there a risk when you look at how you described the government sector and then the private sector and how the divisions are so great, is there a risk of a talent drain going away from the public sector where you need it because of the volumes involved and it being drained into the private sector simply because of economics?
Yes, there is continuous drain of qualified doctors from this country to abroad.
What about within the country, from the public to private sector?
Yeah, no doctor is like to go to a government sector. All the qualified doctor, mainly specialists and super specialists, they are going to private sector, private hospitals, because they get a better platform, better salary, and better livelihood. In government sector, the salary and other conditions are not so good as compared to private sector. So government must increase all these facilities for the doctor. These facilities and these salary packages can motivate doctor to work into the government sector.
It's interesting what you mentioned about Made in India. I'm going to come back to this idea because we talked just a minute ago about innovation. We have a few questions coming from our participants. So I'm going to, there's a gentleman at the back with the microphone. So tell us your name and where you're from.
I'm Dr. Manav. I'm from KPMG. You can hear me, right?
Little closer.
I have a two-part question. First one is about increasing the government budget on healthcare. Do you think the problem is increasing the healthcare budget by the government, or is it about the transparency of or inefficient spending of the government on healthcare currently? Even if we are spending 1% of the GDP, we are not doing it efficiently. That's what I have learned from a lot of primaries we have done.
Meaning it's not being allocated, it's allocated, but it's not being used properly.
Yes, it's not being used properly. So a lot of expenditures, just to give an example, hospitals get money, I'm talking about the public one. It's about what they need. It's not value driven. So hospital doesn't need to show a scorecard to the government for the money. I want to build a new building, so government will give the funds. Government never goes into the part, why do you need to build a building? So just behind there's a Loknaik hospital. In year 2006 or 7, they built a whole new building of almost 100 beds. That building laid vacant for almost 10 years. Still is vacant. It's not being utilized. Government never raised a question, why did you spend? So the money was spent, it was almost 150 CR, which is a huge amount. Similarly, second part of the question is, Do you think the private hospitals are doing justice? Well, they are expecting the patient, controlling 70% of the infrastructure today. A lot of people rely on the private. Are they efficiently treating the patients? Just to give an example, only last night, I got a call from one of my relatives who said his father had an acute MI. And the concept of the acute MI is that you have a golden hour of the treatment. He took his father to a private hospital in Delhi itself. So if you don't get the patient in within 1 hour in an NGO, and being a heart institute, they're expected to do an angiography and plastic at the same time. They have, it's almost 14 hours, and they're just waiting for a doctor to come from home and do the angioplasty. Do you think the inefficiency lies only in the government, or is the private hospital players also playing around with that kind of a problem?
Okay. All right, interesting question. Actually, I'm going to put this to you first, Dr. Tiwari, because of your experience in both sectors.
The answer of your first question, we are comparing the scenario in this country to the world level. In every country, every developed country, the health budget is up to 5, 6, 7% of the GDP. Here, that is very much less. Why? Government is not committed to provide universal health coverage. This is a neglected segment, according to me. We have certain deficiency in our system, like our doctor per 1,000 population ratio is very much low as compared to world average. Our nurses per 1,000 population is very low at compared to world parameters, and technicians and other paramedical staff are also not at par as per the world average. Health infrastructure, 1/4 is the government sector and 3/4 is the private sector. That is the situation, but we need more health infrastructure. If we talk about the bed density, we have 0.9 bed density as compared to world average is 3. So we need more and more fund to generate these bed density, these health infrastructure. As far as fund is required, also transparency and accountability in the system is required. We cannot say that in current scenario with the current budget we can make all kind of health infrastructure which are needed. We need more fund, more accountability, more transparency and more robust system. Part 2, when we talk about the private healthcare system may be a nursing home, maybe a mid-sized hospital, a top tertiary care hospital. The level of care is different at different level. You may not get the facilities in the nursing home or mid-sized hospital as you are getting in top level of hospital. So if we are talking about the quality care, that mostly rare to the top level of the tertiary level of the hospital care, like many tertiary care hospitals in Delhi and Mumbai. As far as government sector is concerned, many hospitals with good infrastructure and top doctors are there, but the confidence in the public is not there because accountability in the system is not there. That is the problem.
Let me ask Professor Brand to touch on this, then the idea that we'll be talking later about regulatory systems, but let me ask you if there's some kind of standardization that can be implemented quite early on, or some mechanism that helps to boost confidence in the public by actually creating this sense of we have certain markers, certain standards we can point to.
There are some European countries where, let's say, you do not have this classical public-private split in running organizations. Charities started hospitals. Is this public, is it private? You can say, oh, charity is for non-profit. Sometimes they make more profit because they exploit the workforce more than the other. So it's always not so clear. But what is clear is that there are some issues, especially regarding public health, where the government has a task. Immunization programs only work when a certain coverage is there. So there the government should be in. Then there should be some guidelines and some rules how what is good practice and liability, all the stuff that we expect. Okay. On the other hand, the government is always not a good entrepreneur. So, but we have to have clear rules how the entrepreneurs can operate in this market. I'm now living in the Netherlands. The last reform there was They always say to make from out of every patient a private patient, because you can start your business, you can open insurance companies, you can start hospitals, and it's a regulated competitive market. And there are certain fees you get for an intervention, and there are some standards, and let's see who can provide the best service. This is possible there for 16 million people. Of course, it has advantages and disadvantages. But it's not only the case that you should ask for more government money. The government can do a lot of intervention in other fields, as we heard, in road safety, in education, that will pay off not now, but later. And the government is the only one who is willing to do long-term investment. In a company, you have a 5-year vision about when you want to have your money back. The government can say we have to improve road safety, we have to have school meals, whatever, to have a healthier next generation. We will invest in preventive programs regardless where you are insured and where the benefit will come back. So this division of work is the most important, and to have a consent and not saying, okay, we need here more, and there are a lot of different things that come together.
Dr. Travis, let me get from you a perspective on this, on how confidence can be built. If there is this kind of disparity, what do you suggest as a mechanism for helping to build some confidence among people here?
I suppose that there are quite a few different ways. You asked about standardization, and one of the things, and you mentioned rules of the game, one of the things I've learned in my working life is that you do need rules of the game, but that doesn't just mean more laws and regulations that then don't get implemented, and sometimes you get multiple laws that just that are contradictory. There's a fashion at the moment, still on the standardization point, there's a fashion for accreditation, which some people see almost as a magic bullet for creating confidence in the quality of services. I think it's an interesting instrument. I think it has to be looked at in a very thoughtful way, because you can just manufacture a great industry of very heavy-duty accreditation. But some notion of publishing statistics and reports and some transparency in the performance of different hospitals that is simple enough to be manageable in a fairly, a lower resource environment, I think is worth thinking about. And then the other thing is improving the watchdog function of different NGOs and CSO groups so that they speak out about quality of services. The press has a role to play. I mean, so there's both formal arrangements for building trust and informal arrangements, I would say.
Dr. Bhatia, actually, this is an interesting thought also. We talked about the kind of the younger generation's expectations, but communication has improved, social media has grown, communication is is quick now, if you like. Could that also be a method for accountability and transparency, as we see in other parts of the world, where people discuss things so quickly online and together that suddenly accountability is built into the system?
Yes, I think that's a fair point, Riz. Today if you look at it, even from the government side, they are using technology as a platform to regularize a lot of things. For example, the Jan Aushadhi scheme that is, launched. A lot of state governments going for the e-governance, e-procurement processes. So a lot of things, and we have seen practically that because of it, a lot of it becoming online, the level of corruption, the level of a lot of red tapeism that used to happen, the stock out rates and all, that has really, it has gone down. Of course, it has to see the light of the day because it's still in its initial stages, but nevertheless, the technology has played an important role in changing all this. And the new generation, because they are more adaptable, so the younger doctors are, more happy to put stuff online. So right. They're more, because they are technologically more advanced, they're happy to do stuff on their mobiles, so that helps actually.
Thank you for your patience. We'll come to you. We'll get you in just a second. So, yeah.
I'm Pallavi from KPMG. Having read about various health systems in Europe especially, so we have seen that systems like UK, they are highly transparent and they are very proactive when it comes to sharing data with the patient and the population in general. If you just log on to the websites, you'll find a whole lot of hospital episode statistics, starting from the admission rates to bed occupancy rates, cost of procedures and everything. So it's very easy for a person like me to track how a hospital has been performing on various indicators. I don't think we have that robust system here in India. So do you think, who should take the onus for this? Like, does government need to come up with a mandate that you have to disclose data with the public? Because we are talking about the patient-centric model and the whole concept of building trust. So where are we as of now?
Thank you very much. Interesting question, because also I think in the US it's become a big debate on hospital costs, and they're trying to create more competitiveness and transparency by actually revealing that. Dr. Tiwari, when you look at, I mean, you've worked in both these sectors, what do you see as to what the young lady said about the publishing of information and transparency of hospital procedures and costs?
There is a process, health audit, and surprisingly in our country, health audit is not a routine phenomenon. In very few hospitals and very few healthcare sector, very few institutes you can see health audit is going on. Otherwise, in most of the institutes and hospitals, there is no health audit at all. So even hospital administrators and hospital concerned people are not aware what is going on. It must be made mandatory by the government, then only health audit process can be started in this country. Otherwise, situation is very grave. Nobody has the data, what is going on there.
Can hospitals, though, like private hospitals and organizations as you've experienced them, can they be kind of a little more forthcoming and set the trend for more information and more transparency?
There must be a change of attitude in the doctors and administrators. Attitude is not there. Nobody is agree to follow a health audit process in any hospital. Wherever I worked, when I tried to start this process, many doctors and many other people registered for this.
Oh.
Only what is the need of this? So
you have natural resistance in the system as well?
Yes, resistance is there. Because many things can come out, what is going on in the healthcare system. But health audit must be there in any institute, in any hospital, and it must be mandatory, mandatory by the government.
Thank you very much. Please go ahead, Dr. Bhatt.
So just on that, if you look at the statistics that the government hospitals have and the public sector hospitals have, all the statistics is up there. Essentially because they have to put up a lot of their statistics online. So it's all available. So whether you want ALOSs, whether you want occupancy rates, whether you want the treatment, and where all that, the major statistics is there. Some of the things on the private sector, I think rightly like what Dr. Tiwari said, I think the hospitals where accreditation has taken place, and I'm sorry, but that has been actually good, because some of the places where the hospitals have gone for accreditation, health audits have happened, and because they are a mandatory process, I think slowly there is resistance, but eventually the entire organizations come through to get that happen.
Okay, thank you. Dr. Rish, I think it is.
Good morning. So I had a chance to speak today afternoon, so Ajay Rish from European Commission. I would like to follow some ideas you mentioned in your speech, but before I do this, it was a question about the one ministry dealing with the regulatory area. I think that there is already a case in Asia. I think South Korean government 2 years ago, the newly created government, decided to put Korean FDA up to the level of ministry, and the chief of the Korean FDA is a member of the cabinet. In China, also the current reform of the government and the role of Chinese CFDA is also higher in the kind of government structure. So maybe there's also a good direction for India, already mentioned I think by you, well, somewhere there during the today morning. But coming back to the two issues, one is the link to the traditional medicine in India and Ayurveda and other Unani medicine and other traditional sector. It's interesting because I'm back in India after 30 years, but 30 years ago, 7 months I studied here Ayurveda, Unani, trying to understand, how this fits to the concept of medicine as such. So this is interesting also for Chinese health system, how to link, this traditional medicine, Chinese medicine with the Chinese allopathic medicine you call here in India. So I would like to understand better what is your idea, how the system should link. In Europe, we don't really have this same situation. The traditional call this herbal medicine is rather limited. We have Ayurveda medicine in Chinese medicine in Europe, but it's also still very limited. But the other issue about the healthcare workforces, because as you mentioned, is one of the critical area. The question is about the way we can cooperate Europe and India on this front, because to train people, first we have to have infrastructure, we have to have teachers, colleges, universities, and you have to jump relatively quick to the new, completely new numbers. And what is your vision how to do it? How to jump from
I'm going to thank you, Dr. Rishi. I'm going to phrase that actually just in the minutes to wrap up and ask each person to give us like a minute and a half summary on this, how this idea of strengthening the system, if you were to use one point of attack to actually change things for the better, what you would do. Perhaps Professor Brandt, if there was the first step for strengthening the healthcare system in a place like India, what would you think would be the approach? I know it's simplifying things, but
have a dialogue with the different stakeholders in society under the guidance of the ministry, divide up clearly the responsibilities, the tasks, and rethink what your original task is. The government should govern, providing good governance. Private sector should run services, NGOs should represent the people not only at election times, but in between, and the media should have an information and a watchdog.
Of course, a crucial factor, the media, which we haven't touched on yet, but hopefully we will. Dr. Travis, what would you look at as the first point of attack to strengthen the system?
Well, I would have probably said the same thing, but I'll build on that and
Please.
say at the same time, establish a culture of monitoring, getting the evidence out into the public domain of who's going where for care, getting what services and how well it's working.
Okay, and Dr. Bakir?
I think, triaging of the care versus the manpower, and then reskilling the manpower according to what care is required, I think that'll help to solve a lot of problems. So the nursing, the lower level nursing care does not really require a GNM to really do that level of care. So that's something that we haven't been able to establish very well, and that's something that's required.
There's also volumes needed, isn't there? Volumes
Yes, there is, and there is a lot of manpower that's available in that category which can actually be mapped to the level of care that needs to be provided. Arvind Naikar again has done a beautiful model like that, where they have actually trained the village girls to perform certain low levels of eye care specialty work that does not require them to be clinicians or nurses for that matter. The other second point is that the training of Ayush practitioners in this 1 year of pharmacological course, I think that has gained a lot of buzz in amongst the medical fraternity. But if we have to find solutions, we do have doctors who are an alternative medicine, who have done 5 years of medical practice. Their level of practice is different. Can their gaps be identified, and can they be reskilled to take off the burden of primary and secondary care? That's something.
Thank you, Dr. Bhatia. Dr. Tiwari.
I don't agree with Ms. Bhatia that Ayush doctor must be allowed to practice this allopathic system, because mixing up many pathies may be dangerous for the patient. A doctor which is trained in Ayurvedic system is not aware about the allopathic system. A doctor which is trained in homeopathic system is not aware about the allopathic system. But sadly in this country, all the Ayurvedic and homeopathic doctors are practicing allopathic system. This may be dangerous for the patient. So there must be a clear line between different pathies, and they must practice their own pathy only. As far as manpower and healthcare improvement is concerned, the first and most important thing is the commitment of the government and fund also. Government must allocate sufficient budget for the improvement of healthcare sector, and there must be a demand from the public also to provide quality healthcare to all. This is lacking. We must demand from the government that you provide quality healthcare.
So, okay, so what we'll do is now we've looked at these elements of, thank you, Dr. Tiwari. We've looked at these elements of how we strengthen the healthcare system. We have 3 more sessions that will be coming up after this short break. We've got how to actually design a health system. Then we look at regulatory, sorry, I'm getting feedback here somewhere. Regulatory systems and then big data. Those are the three areas we cover, and they do all flow in. So I'm glad we have a lot of interactivity in the room, people wanting to take part with their questions. Please do save those questions. I apologize to those who had their hands up now. We will get to the questions in the coming sessions and build in that relevance. A round of applause, please, for our panelists. Thank you very much.